Thanks, Dan. I don't know if it's fair to ask me to follow a race car driver. Oh, that's really good. But Dan introduced me a little bit earlier, but just to give you a little bit of background. My name is David Browder. I'm a physical therapist. I work here in Austin, and we have a private practice with about 25 facilities here in Texas. And as you mentioned, the other thing that we do is we have a national education company that has the largest orthopedic physical therapy residency in the nation. And part of what we've really been focusing on is chronic pain and teaching what's called pain neuroscience education. And Dr. Sprintz mentioned kind of the new science of pain, or the new neuroscience of pain. It's been an area we've really focused on. I'm going to talk about it just a little bit. But for this group, I thought I might start with a little bit more of along the lines of what is a physical therapist exactly? Because I notice when we're going through a lot of these talks, and when I look especially at guidelines, I really hate looking at primary care guidelines. Physical therapy is like a treatment that's sort of shoved in with some of the other non-pharmacological treatments, and I don't know for sure if it's very clear what that means. And I know it's also sometimes a black box of, well, what does the physical therapist do? So I thought I'd spend a little bit of time there, and just also mention that physical therapy, the way it was 20 years ago, is very different now. I feel that quite a bit. I graduated in 1999 and went into military physical therapy in the Air Force. It was at the time a master's degree, and we had just moved from it being a bachelor's. In the 60s, 70s, and early 80s, it was a bachelor's degree, a certificate program, and most of the physical therapists worked in hospitals. In the late 90s, when I graduated from PT school, it was a master's program, and about 3, 4, 5 years later after that, it had become a doctorate all of a sudden. So most of the therapists went back to school, took an extra year of stuff, and got this thing called a transitional doctor of physical therapy degree. Pretty sure it irritates the physicians, sorry about that. But now your typical physical therapist has a doctor of physical therapy degree. They go to get their bachelor's degree, and then they do 3 years of graduate school. It's about 2 years of didactics and a year of clinical training. What we focus on is neuromusculoskeletal systems, right? Pain, motivating patients, and helping them to exercise, get back to function, helping improve movement. We tend to spend 45 to 60 minutes at a time with the patients, and often multiple times a week. Depending upon the kind of practice, we might have more than one patient in front of us at a time, which isn't all that hard to do when you're working on exercise as your primary thing you're doing. The national average is about 10 visits with a physical therapist for a musculoskeletal condition. So one of the things that I struggle with a little bit is that I feel like if you have, for example, and I'm going to talk about back pain here in a minute, if you have back pain in this country and you've lost your narcotics as the primary way to treat it, which is silly in the first place, but you've lost now narcotics as the primary way to treatment, I feel like the primary care doctors are saying, well, what do we do now? Like, what can I offer these patients? And I'm like, this is why we're here, right? Like I went to all this graduate school and stuff just to be able to treat patients non-pharmacologically that have low back pain. And we would like to see some of these patients, if you don't mind. So what we'll talk about a little bit is back pain, and that our referral patterns and how we treat patients with low back pain can have a real impact on whether or not they do some of these things that are harmful to them. We're going to talk about opioid use as a disease almost, right? Or as a disease state to be avoided. We're going to talk about surgeries kind of as a disease to be avoided. And we're going to look at it kind of more from population health perspective as opposed to whether or not physical therapy as a treatment is effective, although there's some good evidence for that as well. PT is really grossly underutilized for low back pain. I cried a little inside when I found this slide. There's 170 million visits in this particular span of time from 1997 to 2010. And I know it's a little bit small, but the little red line on the bottom, that's about 10% of low back pain patients going to see a physical therapist. The line that scoots up towards the top is the total number of visits for low back pain. And the green line you can't really see, that's opioids. Right, so the pattern's pretty clear, and we've talked about it all day so far. And you have a lower rate of being referred to therapy if you are insured by Medicaid or Medicare. Something I can't figure out very well. Medicaid patients, to me, are probably the most susceptible to some of the harms that happen if they aren't treated non-pharmacologically, but are the hardest patients to get in. And if you're insured by Medicare, you're the older patients, and also might benefit maybe the most from physical therapy. So it's not because of payment. Medicaid actually in Texas pays really well for physical therapy, better than a lot of insurers, but it's very hard to get the patients and get into the networks to see those patients. Medicare pays quite well as well, so it's not a payment issue with those two groups. This study was written, I think, just so I could tell you guys about it at this conference. But it came out in December 2017, and it was a one-year retrospective study with 454 Medicaid patients, which I know is not very many, but I think it must have happened in some sort of isolated clinic environment because they were able to get 47 of those patients to receive a consult for PT. It's the only study I've ever seen like this where they looked at the referral pattern instead of whether or not a patient was seen by the PT. 19% of the patients saw a PT. Those are remarkable numbers just by themselves. But what was really interesting is the odds of receiving an opioid prescription in the following year decreased either way. It didn't matter even if the patient went to the therapy. That made me just a little bit sad, but it was still better that the patient got the prescription. If they didn't do that pathway, right? Think of like going to physical therapy as a non-pharmacological pathway. You might put non-steroidals in that list too. If they didn't do that pathway and instead went to specialty care, and I'll feel bad for Bruce, but he's a race car driver, he can take it. That would include Physiatry, even though they send us the most patients. But if they're referred to specialty care or advanced imaging first, the odds of referral to therapy were 25 times less. This doesn't make sense to me, right? Like those should be like your patients with the radiculopathy. They're maybe the worst patients to treat. They're the hardest ones to treat. They need all this extra care. They need to go see an orthopedist. They should probably be, I would think maybe they need therapy more, not less. Like we have this idea that back pain limits itself, but the worst patients here were 25 times less likely to go to therapy or be referred for therapy. So sort of the bottom line conclusion was in this Medicaid group, providing a PT consult rather than opioids is a pretty good way to go. I really liked that study. If we go outside of the Medicaid realm, there's also some evidence that just in primary care referral, if we look in sort of vertically integrated systems where we can look at costs, the physical therapy is a good way to go as well. This was a study, I think it was Intermountain Healthcare in Utah. They looked at 32,000 patients, retrospective, and 7% utilized PT. That's a lot more normal, right? And what was interesting is that if the patient was sent to physical therapy and they saw the therapist within 14 days of their initial episode, then that was associated with decreased risk of all these bad things. More imaging, more physician visits, surgery, injections. Opioids not quite so much, but also correlated. And the total medical cost for the back pain patients was almost $3,000 lower because they received that early physical therapy. This is a similar study, it's even done by the same folks. And what they looked at is an even larger group, about 750,000 patient records, where 112,000 of those had a referral to PT. That was about 16% who were sent. If they had that early PT, same category, less than 14 days, then they had less imaging, injection, surgery, or opioid use. And this is where it got a little bit interesting. The question is like, well, what does the PT do and does that matter? And what they found is that it really was more important, it was really more important that the referral was done early. The referral pattern itself was more important than what the physical therapist actually did. I would have preferred it, that what the physical therapist did made a big difference, but that wasn't what we saw. We really saw more that early referral was more important. But again, less of those other bad things and less cost. But just because we're also talking about what PTs do, I thought I would talk a little bit about what this idea of guideline adherent physical therapy means. Like what does a good therapist do? Be mad at me if I say good versus bad, but what is an evidence-based approach for most musculoskeletal conditions? How would you choose whether or not a therapist was sort of up to speed on these things or if they were behind the times? And what this particular study, which I think is a good way to look at it, looked at was whether or not the interventions were active or not. Did they use things like therapeutic exercise or neuromuscular reeducation? Another thing you might see in terms of neuromuscular reeducation is the idea of motor control exercise, that type of thing. If they used manual therapy or manipulation, was it used as an adjunct to those more active things, or was it done alone? Evidence says that it's a very useful adjunct. It's a good way to help people get moving, but by itself, it probably isn't very effective. Particularly early manual therapy plus exercise is the way to go with most things. Knee arthritis being an example in addition to low back pain. If The more passive things, and I like to think of this as sort of my father's physical therapy or like the 1980s version of physical therapy, were not very useful, and there's plenty of evidence showing that it's not. Ultrasound, electrical stimulation, heat packs, traction, any of the modalities. If you say modality, you're probably off into things that have been shown not to be effective. And manual therapy all by itself, particularly in patients with chronic pain, not very effective. So that's something to look for when you're choosing therapists to work with. So what are some other, if I dig into those, a couple of active interventions, how would we go into looking at a little bit more into what each of those is? A typical therapist might work, for example, in back pain with trunk coordination, strengthening, endurance exercises. Patients with distal symptoms or radicular symptoms, we might look at centralizing those symptoms, right? You might hear the word McKinsey every once in a while, which is an approach that really focuses on which preference a patient has in terms of what direction their spine goes, and then gives them exercises that help them centralize their symptoms. Patients with stenosis often respond really well to flexion exercises. And then most therapists do some form of manual therapy or manipulation. As we get into more chronic pain, right? So these are good things for avoiding chronic pain. But as we get into patients that have more chronic symptoms, hands-on work becomes less and less important. Which exercise we do becomes less and less important. And just the fact that we're helping a patient get moving becomes kind of the point, right? And as we get to those more chronic patients, we're looking more to provide progressive endurance activities and exercises, coaching function despite discomfort, teaching patients that harm and hurt are two different things. And then this idea of pain neuroscience education. So Dr. Sprintz mentioned earlier that that there's a lot of evidence coming out that a lot of the pain experience a patient has happens up here in the brain, right? And that the actual injury is much less the problem. And as the patient gets more and more chronic, I think that's more and more the case. We've known this for a long time. We like to call it a fear avoidance model to some degree, maybe 10 years ago, and although the terminology is changing a little bit. Basically, the patient gets scared and they ratchet up their nervous system and become much more reactive to things that maybe normally wouldn't cause pain and certainly wouldn't cause injury. So the therapist plays a role here, and we think that the therapists need to have a bit of additional training. So it's something we've really focused on. And the way that in a physical therapy brain, the way this works is we utilize pain neuroscience education as an adjunct to the rest of the things that we're doing. So we might be doing all kinds of different things, but also giving advice to the patient and helping them learn that it's okay to move and that they aren't going to hurt themselves, right? Now, a lot of times that's the problem with the patient is everything hurts. I'm not sure what's safe. I'm not sure if I can go walk 2 or 3 blocks without hurting myself because it actually hurts while I'm doing it. Am I going to get better from that, or is it going to make me worse? Part of the therapist's role is to help the patient navigate that and to help them learn how to ratchet down their nervous system, take away some of the anxiety associated with movement, and help them get back to normal activities. There's some decent evidence around this. This is a review of 6 randomized trials. I didn't want to include all the details, but it basically says that there's compelling evidence says this works. For those of you that like numbers, I like this idea of the numbers needed to treat, right? For our physicians in the room, I think you'll appreciate this. For function, using a combination of pain neuroscience education and physical therapy, it only takes 2 patients to make one of them quite a bit better. And for pain, it's more like 3 patients to make one of them better. Now, those numbers are not very impressive unless you're familiar with this kind of statistic. So I'd like to compare that to opioids, which has been everybody's favorite way to treat these patients for the past 2 decades. In order to get the same kind of pain relief, you need to use oxycodone plus paracetamol, which you can get a 50% reduction in pain in 1 out of 3 patients, and then they become addicts. But we aren't psychologists. I'm sure we have some psychologists in the room. This is not the intent isn't for physical therapists to try to do sort of junior league psychology. You might call it psychologically informed physical therapy and just maybe doing a better job with chronic pain patients. If we just have a therapist trying to do pain neuroscience education and using that as an intervention, it's not very effective. It's really only effective if it's used as part of teaching the patient how to move again. So what are some barriers that a patient might encounter, right? So we, as therapists, we have this issue that physicians don't always refer to as patients we think would really be helped by therapy. But really, part of the problem is that the patient may not be informed that we can help at all. And so even when the physician refers the patient may not go because in their head, the therapist is who helps them adapt to the environment they don't want to have, right? You think about a patient, you see this on TV, physical therapists, right? We're always helping an amputee. Or maybe somebody with a stroke, adapt to their current environment and have to function how they are now, as opposed to being a profession that really helps people decrease their pain, get all the way back to function. There's a lot of variation in our practice patterns, just as in any of our professions. And there are therapists out there that are not very good at what they do. And of course, there's the opposite, therapists that are really up to speed on how to treat these chronic pain patients. It's not a quick fix. I know it's really annoying to tell a patient they need to exercise and that's what's going to fix their problem. And it's hard to do. It's hard to tell a patient that that's what they need to do. And it isn't something you can go to therapy for one visit and expect it to have a huge impact. It takes time and it takes work, and patients don't like that. They'd much rather have the quick fix. And then unfortunately, there's a lot of insurance barriers. We're a silo, and one way to knock down a silo is to put a pre-authorization on it. But there is a lot of pressure to do more early physical therapy, and it's coming in large part from industry who's tired of paying for the more expensive stuff, right? We're cheap. I'm sure you're familiar with this 2004 Virginia Mason study that they partnered with Aetna and Starbucks. And what they did is they really changed the pathway. I don't have my laser pointer here, but in this little pathway over here to the side, you have a patient on the right that goes to therapy first, and then if that doesn't work, then they access a specialist and an MRI and all that kind of stuff. On the left is the more traditional approach, which is what we more typically see, where a patient will often go to a primary care provider first, the primary care provider sends to the specialist sends to us sometimes. But by that point, they're 30, 40 days in, they've had an MRI, they've already spent more than the entire cost of therapy times 3. Prescription medicine wasn't even needed in 75% of the cases in this case study, and they saved about $1,000 per case. They had 1/3 fewer diagnostic images, patients loved it, and they had 2/3 less work days, right? If you're familiar with this, it's probably because Michael Porter wrote about it pretty extensively in an article called The Strategy That's Going to Fix Healthcare. And I think that I'm going to try to steal that, as this is a pretty good strategy to fix some of our healthcare issues. Another issue we have, especially here in Texas, is we have we're proud to be one of 6 states that limit patient access to physical therapy. Go Texas. I'm not saying that my physician partners aren't necessary. We're 100% part of the medical model, but my patients can go see a massage therapist, an acupuncturist, a personal trainer, a chiropractor. They can see they can see pretty much everybody but me without going to see their primary care doctor first. That I think is a problem, and it adds, at minimum, it adds 7 to 14 days because my access is much better than the primary care doctors. I can get patients in 24 to 48 hours. And then since we're here with Superior, Medicaid and underinsured patients have larger problems. And one of the biggest challenges is that Medicaid providers, I think, need to expand networks beyond the traditional hospital-based provider who typically provides care to Medicaid. I'm in a private practice. I take Medicaid, but I can't see most Medicaid patients, right? And it's because I'm not in a narrow network. If you look at the number of patients or the number of providers that are able to see Medicaid, there's a lot of them, but they all work for Seton. And Seton has about a 3-week wait list, or at least they did last time I checked, right? Because they are flooded with these patients, and they aren't the primary patient that they're trying to see. They have to see all the patients from the hospital, right? And patients also don't like driving to a hospital to get physical therapy. You need to be seen in your community if you're going to be seen twice a week or 3 times a week for a problem. So increasing PT access and using a metric of time to access versus just the number of providers, I think, is one way to improve that. And we think it decreases opioid prescriptions and downstream costs. I was really tickled that the dean mentioned the joint program with UT physicians. We had the honor of being the therapist that were able to help with that. And so I wanted to share, just kind of in closing, our experience with the Travis County Medical Access Program. This is a program for underinsured patients. And what we found we were able to do is we were able to save them about 15% on what they were paying the hospital-based providers, and yet drop access from about 3 weeks to 24 to 48 hours. We haven't abused it. We see patients for about 8 visits. It's not our best payer or anything like that, but we've been really honored to be able to take care of some patients that normally can't receive therapy even after they have things like a total joint surgery. We think we can do very similar things with low back pain and other musculoskeletal conditions. I have no idea if I talk too long. I usually do. Do we have time for questions?
Absolutely.
Oh, I'm fabulous this time. We have a few minutes for questions. Apparently, a race car driver was really fast. Yes, ma'am. Absolutely. So just a little bit of background, I spent about 10 years in the military healthcare system where physical therapists had direct access. It is a little bit harder in the civilian setting to really do that, right? So some of the tools we had in the military, we could order radiographs, we could prescribe nonsteroidals, and that made it a little bit easier to be a first-line provider. We could do erythrocyte sedimentation rate, and so we had some ways of just doing some basic screening. I think the best we can do in Texas, short of changing the laws, is to have a very tight partnership between primary care and physical therapy. The earlier we can get that, the better. Another way to think about it is in a way that you might be able to sort of put into an insurance program or something to help incentivize that is to require some of these non-narcotic, non-invasive things like physical therapy before you do these other things. Instead, we tend to go the opposite direction where I've got to get pre-authorizations and they take a week and this type of stuff. The more barriers we can remove, the less the copay is, those type of things really help. Yes, sir. Is there a live mic? I don't think I can do it. Oh, that's a good point. This one works. I can walk.
I just want to give a testimony for you.
Please do.
So when I did my fellowship in England in 1990 and 1991, those were the years that Pennington et al. Took the Public Health Service from their system that looks like ours to a system where all back pain complaints throughout the UK were first vetted by a physical therapist. It was a massive transition, and of course they had to train the physical therapists in some algorithms not to miss osteomyelitis and discitis and metastatic tumors and so on. But they actually know how to do that anyway. There's a good paper by Pennington, if any of you wanted to see this, and this would be really applicable to this project that showed the success of that. Patients were happier, primary care was happier, visits went down, cost went down, results went up. So the whole PHS, the whole public health service in Britain went to the back pain model of having the physical therapist see them first. And I think they're still doing it. That was a huge success. So that backs you up.
Are there any more fabulous questions like that? Here, I'll do this. Is easy.
Dr. Shadow with the Texas Pain Society. Thank you for coming and sharing with us. Let me give you a scenario, because I refer to physical therapy often, and it helps my patients a lot when they'll go. Failed back surgery syndrome. Patient shows up. In the history, he says, I've just been to Colorado, I actively use. How are you going to change your treatment plan, or are you?
Meaning actively use narcotics? You just described like half of my caseload. Yeah, I mean, the reality is that most of our patients are, heck, they're addicted to narcotics, right? I don't know how long it's been since I haven't had to write Percocet on a patient's medication list. Honestly, we don't try to address their addiction or their active use of pain medication. The best we can do is try to hit the underlying causes. Hopefully they don't always still have it, but hopefully they still have a musculoskeletal cause for their chronic pain that I can address. the further out it gets, the longer, the further out we are from whatever, quote, injury they had, they've been able to pick up a pencil and hurt their back or whatever it was, the less likely it is that they have a pain generator I can find or that they have something I can treat directly. And the more of that there is, the more sort of psychological overlay there is, the more we focus on just getting that patient moving and just getting that patient being more active and back to their life with hopefully less medication. But I'm not a physician. I don't try to take a patient off of any of their medications at all. But we do try to take the reason for the medication away to the extent that we can. That answer that question? No?
A follow-on to that.
Yes, sir.
The medical board will not allow me to treat. They're actively using. Okay? Does your board restrict you from patients who admit to using illegal substances?
No. If a patient were to tell me that they're, I don't know if I've ever had a patient say, you know what, I'm just taking all these pills. But if they did, I would still probably treat them. I don't have any active reason why I can't. I'm not trying to give them more pills, so I'm usually okay. Anybody else? Yes, sir.
So as you're trying to, first of all, every time I'm doing, before I do an injection, after I do an injection, before I write a pill, after I write a pill, my always go-to sentence is, the only reason I'm doing this is so that you can do physical therapy. Eventually, the real treatment for chronic pain across the board is physical therapy.
I'd just like to repeat what he said. He just said, you know, eventually the treatment for all chronic pain is physical therapy.
The reality is, chronic pain is very unlikely to continue and exist and chronify if the animal moves. And that is the reason why it is so hard to create animal models of chronic pain that are sustainable and testable and reproducible. You know, because if you move, it gets better. And that's the whole that's the whole principle of the multidisciplinary treatment, the Podician models, and all of that. You get them moving, it gets better. Whether it's with narcotics or without narcotics, majority of them, they get off narcotics, and if you take them off narcotics and get them to move, they will move and they'll get better. But the big challenge is, how do you actually, of course, I just stated my philosophy, and we know it works. We know that there's plenty of literature with hundreds of thousands of patients in multiple countries that has shown that it works, it saves money, it reduces ER visits, people don't die. But how do you actually translate that into a population-based care? So how do you see that being implemented in, let's say, a county surrounding area where we can leverage, the few, or maybe there are many like you who strongly believe in getting over the kind of suffering and getting moving rather than just massaging and getting the patient to leave, right? So I always ask my patient, okay, you've been to physical therapy, what did they do? 90% of the time, oh, they put this machine on me, they massage my hand. And I tell them that the only thing that got stronger is the therapist's hand and wallet. Nothing was fixed. So how do we actually replicate people like you? How do we spread that philosophy so that a healthcare organization can say, hey, this is the model, and we know that this guy and his 3 friends have this philosophy, and we need to deploy this for 50,000 people who come to our hospital.
That's a great question. In a nutshell, he was asking what is there a way to replicate that and really make it easier to access across a population? I think,
Sorry, because the quality of physical therapy, as with any other treatment, right, any other professional service, it can vary highly.
how do we address the variability in treatment you get, even in physical therapy? Well, part of the evidence says that early physical therapy referral, that pattern by itself, from a population health perspective, is useful regardless of what the therapist does. I know that sounds a little bit like BS, but, and I'm all about, like I said, the name of our education company is Evidence in Motion. So we're a PT company that was started by a bunch of PhDs. Half the research that I presented was done by our partners. But I think as a profession, as a physical therapy profession, we have to do a better job of upping our game. As we want to be a bigger part of the healthcare profession, we have to do a better job of taking our own evidence and taking the evidence and really putting it into practice. There's a couple ways we try to do that. One is residency training has become dramatically more common. I've got 45 residents or so in just in our company. The other piece is that about 93% of therapists are generalists right now. Which if I said that for physicians, right, like 93% of physicians are generalists, that would be really weird, right? But about 7% of therapists have done a specialty. There's an American Board of Physical Therapy Specialists. So one of the things our company is really focused on is trying to improve the numbers of therapists that are doing specialty training. That's why I focus on residencies. Because that really guides us more towards evidence-based practice. And evidence-based practice is where we get to things like active interventions. And it's not rocket science, it's just really avoiding passive interventions. So it's just like anything else, just like trying to get primary care doctors to not use opioids for low back pain. For physical therapists, we have to make sure they aren't using modalities and use things like therapeutic exercise and manual therapy.
We're going to dominate those. Is that okay? To this question, to answer your question, the pain echo programs can help too. One of the things that the pain echo program I'm part of does, great effort, makes great effort to do is teach primary care providers when to call on physical therapists, what to expect. Everything you just said, part of an echo training program from physical therapists who are talking about it. And in each case, we sort of read, here's how you would use a physical therapist. A lot of this depends on the primary care provider to request a pain consult, but tell the patient ahead of time, I want you to see the pain specialist for the purpose of facilitating your rehab. And they're coordinating with the physical therapist at the same time. So that is a competency and next gen primary care training that we speak to in ECHO program.
That's a great point.
From that side as well as from organizations like yours, training the physical therapy workforce up, training the primary care workforce up. I think that's amazing.
That's a great point. His main point was that's what Project Echo is all about, which is why we're here. So it's a really good point. I will say that one of my favorite groups of physicians to work with, physiatrists send most patients to physical therapy in the U.S., and they get a little bit of a bad rap sometimes, but the interventional pain medicine physician that does things like transforaminal epidural steroid injections are who we refer to all the time, to the extent that we pretend like we don't refer. We kind of go back through the primary care doctor, but really we're sending the patient to the pain doctor because often the interventional pain medicine physician is the one that can knock out that nasty radicular pain, and the patient can do exercise for 3, 4, 5 weeks and often get to that next level of being able to get better. That's what I did for my back when I got a radiculopathy. Took 2 transforaminal epidural steroid injections and a lot of therapy, but I didn't have to have surgery. So.
And that's what they were referring to earlier. I've had 3 herniated discs, 2 surgeries, and the epidurals and all of those things can definitely testify that that's what got me back on the road to physical therapy, exercise, and now walking and biking the lake every day.
No, I suspect that I now have to get off the stage because we've got a schedule, right?
We've got a break, actually.
Okay.
So, yeah, but I want to make a couple points. All of this conversation has been teeing up this idea that we want to establish networks of excellence throughout the state. We want to be able to identify who are the best physical therapists. As we've heard, there's a huge variation in the quality in physical therapy as there is in any other type of specialty. So the part of it is identifying organizations like David's and this Evidence in Motion, but it's also your testimony too. You're saying back to us, hey, these are some great physical therapists in our community. If they're not in network, you guys should think about getting them in network, that kind of idea too. And then we can build this database that leads to this idea of networks of excellence that will essentially be a searchable database that can help you then when you want to make those referrals. The other barrier that we have to deal with as a Medicaid managed care organization is that Medicaid state policy says that you can't use physical therapy for chronic conditions. So that leaves then the person that's making that referral put in the position of deciding, is this an acute exacerbation, is this an acute injury, Or is this that same chronic condition that we've been seeing forever, but maybe the light bulb went off and, well, maybe I should try physical therapy?
Sorry, Dan, I do have to mention that, in the really weird ACP guidelines that they just replaced in April, it had only acute was where you should use, or only chronic was where you should use physical therapy, and then the Medicaid policy was exactly the opposite of it.
Exactly.
Which is all a little
And
bit silly.
she's not sitting here right now, but Sue Bornstein, who's a regent with the American College of Physicians, so that's nationwide. She's at the top. She helped to write those guidelines, and that's one of the reasons I wanted to make sure that Sue is here. But what you're going to hear about tomorrow at lunch is how a managed care organization can, using alternative payment models, come up with ways that perhaps what we can see is new methods for paying for episodes of care, bundled payments, where we're not paying directly for a service, but there's an entity in the local area, an ACO-like entity, something like that, that can get the payment and then divvy it out to the providers that are doing all this great work. So they can get money to the physical therapist that's compensating them for the care that they're providing, to the cognitive behavioral therapist, to the substance use counselor, whoever it is that you want to get involved. And then the other shout out too is we're going to have a session tomorrow on the role of yoga therapy. And I think that there's a lot of evidence that's accumulating on yoga therapy and how it can really complement physical therapy, and in some cases can be that transition where the physical therapist has completed their round of therapy. You want to sustain that activity, make it even better, get a yoga therapist, and you'll hear about this. A yoga teacher is someone with 200 hours of training. A yoga therapist is a total of 1,000 hours of training, and they can be certified and get the process so that they are used to working within the medical community. And we're going to hear some great examples of that tomorrow during breakout sessions. So with that, we're 10 minutes ahead of schedule. Let's be back in here by 2:50 for our next session. And get out there and make some friends.
Yeah, so we caught up.
Yeah.